Imagine you are 85 years old. You have lived through more than 8 decades of this world. You have lived through more than 8 decades of this world. You have outlived storms, losses, and challenges that would have broken people half your age. You wake up in the morning, you move through your days with intention, and the things that matter most to you are clear. Your family nearby, your mind intact, your body doing enough to let you live on your own terms. Now imagine that a routine hospital visit, a checkup, a fall, a brief illness, sets in motion a sequence of procedures that leaves you bedridden for 3 months. Routine hospital visit, a checkup, a fall, a brief illness, sets in motion a sequence of procedures that leaves you bedridden for 3 months, disoriented, dependent on machines, and further from your own home than you have ever been. That is not a hypothetical. That is a documented pattern in modern geriatric medicine. And the reason it keeps happening in hospitals across the country is not malice. It is a mismatch between the age at which certain protocols were designed, and the reason it keeps happening in hospitals across the country is not malice. It is a mismatch between the age at which certain protocols were designed and the age of the patients those protocols are now being applied to. Today, we are going to talk honestly about 3 specific medical interventions that the geriatric medicine literature now recognizes as warranting careful reconsideration. These are not fringe positions. They are documented in peer-reviewed research. These are not fringe positions. They are documented in peer-reviewed research, in official clinical guidelines, and in the candid assessments of geriatricians who spend their careers caring for the oldest and most vulnerable patients in our healthcare system. This video is not telling you to refuse medical care. It is not telling you that your doctor is wrong. It is giving you the language and evidence to have a conversation, the kind that leads to decisions your loved one can live with, not just decisions that keep them alive by the narrowest definition of the word. Let us start with the foundation. There is a concept in geriatric medicine every family should understand. It is the difference between chronological age and biological age, or physiological reserve. Chronological age is the number on the birth certificate. Biological age is the answer to a more complex question. How much capacity does this person's body have to withstand a major stressor and recover from it? A 50-year-old who is sedentary, diabetic, and dealing with multiple chronic conditions may have less reserve than a vigorous 80-year-old who walks daily. The number alone tells you very little about what a person can tolerate. What the research on frailty, the clinical term for reduced physiological reserve, consistently shows is this. Frailty is a state of decreased physiologic reserve that increases a patient's susceptibility to incapacity and, by definition, increases the risk of poor surgical and procedural outcomes. A landmark study from Johns Hopkins, published in the Journal of the American College of Surgeons, prospectively measured frailty in nearly 600 patients aged 65 and older preparing for elective surgery. Frailty independently predicted postoperative complications, length of hospital stay, and discharge to a skilled or assisted living facility rather than home. Frail patients were over 20 times more likely to be discharged to a care facility rather than returning home compared to non-frail patients. 20 times. That is not a marginal difference. That is a life-altering one. In frail individuals, stressors such as surgery can precipitate an acute deterioration in health. In frail individuals, stressors such as surgery can precipitate an acute deterioration in health, manifesting as delirium, falls, reduction in mobility, or continence, rendering these individuals at an increased risk of adverse outcomes. These are the very things that determine whether an elderly person can live independently. They are the difference between home and a nursing facility, and they can be triggered by any disruption. The preparation for a procedure, anesthesia, a prolonged hospital stay, or an infection acquired during the admission. The philosophy that more medicine is always better medicine is simply not supported by evidence. And understanding that is the foundation for everything that follows. The first intervention is aggressive cancer screening, specifically colonoscopy and mammography, in patients who are in their mid-80s or beyond. Let us be precise about what the evidence actually says, because guidelines and practice sometimes diverge in ways that matter enormously to patients and families. The U.S. Preventive Services Task Force is an independent, recognized panel of experts. Their positions represent the most rigorous synthesis of available clinical evidence. They conclude that colorectal cancer screening in adults aged 76 to 85 years has small net benefit. This applies to colonoscopy, CT colonography, and stool-based tests. Screening is not recommended for adults over 85. Let that land clearly. For patients screened throughout their lives, the benefit after age 75 is characterized as small. The reason is biological. Most colorectal cancers grow slowly. The benefit depends on whether a patient has enough remaining life expectancy for the cancer to progress. Meanwhile, the risks are real. Colonoscopy preparation, the bowel clearing process, is a medical risk. For an 85-year-old with reduced kidney function, it can precipitate falls and confusion. The procedure itself involves sedation, another stressor on an aging system, and the recovery period represents additional vulnerability. On mammography, the evidence is insufficient to assess the balance of benefits and harms in women 75 or older. The risk of false positives leading to biopsies and unnecessary treatments is a serious concern. The question is, if a cancer were found, what would we do about it? If treatment is more dangerous than the cancer itself, then what is screening achieving? It means the conversation must happen. It means the discussion must include the patient's overall health status, their functional reserve, their personal values, and a realistic assessment of what a positive result would actually lead to. It must include their health status, personal values, and a realistic assessment. The second intervention is routine stenting for stable coronary artery disease. To be clear, this is not about emergency heart procedures like heart attacks. The question is about patients with stable angina, chronic chest discomfort caused by narrowed arteries. The question is about patients with stable angina, the chronic chest discomfort caused by narrowed coronary arteries that is managed over time, being recommended for elective stenting as a routine first-line intervention. The ischemia trial randomly assigned over 5,100 patients to either revascularization or medical management. There was no significant difference in cardiovascular death between the two groups. For stable coronary disease, medications were just as effective as stenting at preventing heart attacks. A meta-analysis of 14 trials reached the same conclusion. Revascularization didn't reduce mortality. First, the risks of the procedure itself, cardiac catheterization, stent placement, and the anesthesia and physiological stress involved are meaningfully amplified in a frail 85-year-old compared to a 65-year-old patient. The cardiac catheterization, stent placement, and anesthesia involved are stressors. Second, stenting requires taking dual antiplatelet therapy, blood thinners, for a prolonged period. In an 85-year-old at risk of falls, blood thinners increase the risk of catastrophic bleeding. The clinical math for this population often tilts differently than it does for younger patients. The benefit of symptom relief must be weighed against the procedural and anticoagulation risk. If your loved one is 85, the right question is, does the evidence support this procedure as first line? Or should we try optimized medication management first for someone with this functional status? The third area requires the most care and the most compassion to discuss. It is also, many geriatricians and palliative care specialists would argue, the most important. It is the question of ICU admission and mechanical ventilation, being placed on a breathing machine, for an 85-year-old with multiple chronic conditions who experiences an acute health crisis. We need to discuss this because families deserve to understand the outcomes before a crisis, not when you're in a hospital corridor at 2 a.m. being asked to make a decision in minutes. Mortality following emergency intubation was 43% for ages 85 to 89 and 50% for those aged 90 and older. Only 24% of survivors across the older adult cohort were discharged to home. Overall, 6-month survival was 26%. Age 85 and older, poor functional status before ventilation, and significant comorbidity were the strongest negative predictors of survival after discharge. Less than 5% of those aged 85 and older were eventually discharged home. At 6 months after the ICU visit, 63% had either died or experienced functional deterioration. Only 1/3 of survivors at 6 months were independent for all activities of daily living. There are circumstances, a reversible, acute infection in an otherwise vigorous senior, for example, where it can absolutely be the right choice. The key word in all of this is reversible. The crucial question is whether the underlying condition driving the crisis is one that the body can recover from, or whether the ventilator is sustaining life through an irreversible process while accelerating the very decline it is meant to prevent. Comfort care and palliative support are not giving up. They are a deliberate choice to prioritize being free from pain and being with the people they love. This brings us to what all of this means practically, what you can actually do. There is a single question that can cut through the complexity of almost any situation. Will this procedure return my loved one to their current level of independence, or will it simply keep them in a hospital bed longer? That forces a direct, honest answer. The other concrete step is the preparation of an advance directive, a living will, where you state, while well, what interventions you do and do not want. Without this, the default in most hospitals is to do everything. Every machine, every procedure. Not because it is what the patient would want, but because it is the institutional default. If they don't have one, that conversation is worth having this week, not when they are sick, now. The actual voice of the person they love, speaking about how they want to be cared for. If they don't have one, that conversation is worth having this week, not when they are sick, now. It's not a conversation about dying. It's a conversation about living on their own terms. The 3 interventions we discussed, screening, stenting, and ICU ventilation, are not rare. They happen in hospitals across the country every day to families without this information. More medicine is not always better medicine. The most compassionate intervention is a conversation, one that takes time to understand what matters and what a good outcome looks like. Have you or someone you love faced one of these decisions? Tell me in the comments. Your story matters, and it may be exactly what someone else needs to hear before their own difficult moment arrives. Protect your peace, protect your health. I'll see you in the next video.